All right. Greetings, everyone. We are live, and I am so excited to have in my presence, or at least in my virtual presence, my colleagues that I really have had the honor to work with throughout the years. Today, well, first of all, welcome to Heart to Hand's World AIDS Day discussion. In lieu of having a big event out in the public where everybody would be together just way too close. We welcome you to join us virtually. And today I'm really pleased to welcome my colleagues from the Maryland State Department of Health, from Montgomery County Department of Health, and also from RAHMA, which is a local organization that's located in DC. So I'm going to let everybody introduce themselves. But my name is Ann Wiseman, and I am Deputy Director at Heart to Hand. We are located in Largo, Maryland, and we do work. We've been in the community for more than 20 years doing work supporting folks who are HIV positive to live their best lives. And so I want to give a chance to welcome my guests, and I'll let Mr. Woyah go first, Augustus Woyah, who is from Maryland State Department of Health. Augustus.
Yeah, thank you for having me, and thank you very much for affording our department the opportunity to be a part of this. To introduce myself, my name is Augustus Woyah. I serve as a program officer focusing on minority AIDS initiative program and providing support for providers who work with African immigrant communities so that they can provide culturally and linguistically appropriate services. Again, I work for Maryland Department of Health as a program officer, and I'm so happy to be here. And I will really start by just saying thank you to all the frontline public health professionals who, in the midst of this epidemic, are risking their life to ensure that this epidemic comes to an end. Your work is acknowledged, and you are in our prayers. Thank you.
Absolutely. Melvin from Montgomery County Department of Health, Mr. Cauthen. You're on mute. That's all right.
Okay. Hello, everyone. Very happy to be here. Melvin Cauthen from the Montgomery County Department of Health and Human Services. I'm the administrator of HIV services here of all programs. Actually, it's a role I've had for about 6 weeks, so the ink is not completely dry. I have been with the county for about 10 years. I've worked as a social work medical case manager and supervisor. I've been affiliated with HIV, or certainly working in HIV, from the span of being a volunteer to my role now for probably the last 30 years. So this has been a real passion for me. We're currently working on in the HIV epidemic plan for Montgomery County. It is probably important to note that we in the county see about more than 70% of the folks that we see at the health department are foreign born, from sub-Saharan Africa and Central America. So this is an important conversation, and I'm happy to be a part of it.
Yeah, thank you. Thank you so much. And then I am so excited to have Kadijah Abdullah join us from RAHMA, which is an organization that's located in DC, and I'll let her introduce herself.
Thank you, Ann. Thank you for having me. So my name is Kadijah. I'm the founder of Reaching All HIV Positive Muslims in America, aka RAHMA. It means mercy in Arabic. And our goal is to try to do our work with the goal of having mercy and compassion as our lead. We were founded in 2012. We started off focusing on the Muslim community. HIV is such a stigmatized topic. No one talks about it really, even sex. And I met a Muslim man living with HIV. Actually, he progressed to the AIDS stage when I was a student in college. And, he shared with me the stigma he faced in his community. He doesn't feel welcome or safe. And it really bothered my heart. It troubled my heart. And then my friend, who was 19 at the time, became positive as well. And I was like, okay, you know what? I need to understand HIV. I need to learn more about it. So I went to my college campus. We organized World AIDS Day events, actually, for the whole week of World events. And very, very well. And I changed my major to public health because I realized this was my calling to kind of focus on HIV and AIDS, community education. So I founded RAHMA, and starting off still being like not really knowing how to run an organization. The first couple of years are kind of like just something that we're doing. But then around 2015-ish, we started doing more work in the community, educational workshops. We raised awareness, and then we got a grant with UW here in DC, and we also do work now on FGM, which is female genital mutilation. And a lot of people that we work with are from, our African background. And we created a toolkit for survivors of FGM/C, so you can say cutting as well, depending on, who you're talking to, and a toolkit for healthcare providers. And the goal was to kind of provide information on how to provide competent care. Because some people have felt that they went to see a provider and didn't understand what was going on with their vaginas, pretty much. And they felt like they're bringing like students like staring at them like they're at like a zoo at a circus, something like that. So the point was to kind of lead providers to understand what they're looking at, what it is. They'll make faces at someone when we're seeing their private area, how to help them if they're pregnant, how to navigate them through that process, how to provide care where they feel safe and feel welcome when they're in your office. I had one person say she never went back to her doctor after 10 years because when she first went, they seemed judgmental. So we had this toolkit at fgm2kit.gw.edu, and it has everything about that we've done. And right now, we actually have expanded our work to include men and faith leaders because they are very important in making noise and also helping protect their women and girls. So RAHMA, we do a lot of different things: HIV, AIDS, FGM, and sexual health. And our goal is just to create spaces for people in faith communities. We started off the Muslim community, and now we've done more. And also, we're the founder of State HIV/AIDS Awareness Day, which happens every August. So that's one of the big things. And this year, we became federally recognized. So we're really excited about that. So yes. HIV calendar, yes, it was like a couple years in the making, but we're really happy about that. It's a really important Awareness Day. So.
Congratulations for that too. That was an awesome accomplishment. And so yes, I mean you can all see like I'm very pleased to have this particular group of folks with me to have this conversation today. Today we're focusing for our World AIDS Day, we're focusing on support for folks who are African born or even first generation, and where to fall in a safe place where we can get care for folks who are living with HIV or even who are at risk for HIV, where you can get tested and where you can get connected to PrEP and other prevention methods. So just really, where does that round, you know what I'm trying to say, the wraparound services, where are they? So this is going to be a discussion. As I mentioned to my colleagues, there's a list of questions, but I promise not to go through the list just one by one, because I really wanted to have a discussion. We are all very passionate about this. And I've had a chance to have a lot of, off-camera discussions around how important this work is. I know at Heart to Hand, even in the past 4 years, our caseload has probably doubled every year in the past 4 years. When it comes to folks who are African born, who are foreign born. What does it look like for your organizations? Kind of what does the lay of the land look like? Because I think this is such a hidden population. And so it's important to let them know that we're here. So what does it look like in terms of the state, Augustus?
Thank you very much. I will start by, going a little further in your question. African HIV is not only a health crisis for African on the continent of Africa. It is also a major health crisis for African born living in the United States of America. In areas or jurisdiction where HIV data is collected by place of birth or country of birth, African account for the higher cases of HIV in every jurisdiction. Specifically, coming to Maryland, in 2019, we had a total of 92 Africans tested positive for HIV, and the total rate, the total cases of new cases
in Maryland in 1993 was 931, and we, mean African, being the highest of among all foreign born, is indeed a major crisis that we all are concerned about and want to work aggressively with the community. And what has worked for us in the past, in between my past year of working, is that no one organization can independently address the issue of HIV and succeed. We need community mobilization. We need community involvement. We need to have faith leaders involved, country-specific association, like the Nigerian Association involved. These people open corridor to accessing the community members. And many of you here, my colleagues that have started this journey. I worked with Melvin closely a few months ago to connect him to the African and other immigrant community leaders to have them at the table. So there's a lot that can be done to address this crisis among African, and we need the providers to get these community leaders involved. And I also, if you're an African community leader under my voice, or African living with HIV under my voice at this time, I just want to encourage us to, as much as we want to encourage providers to get our community involved, we can't sit and be so passive. We have to be proactive. We want to join HIV Council in your region for your voice to be heard. You want to be at the table, because if we are not at the table, we'll be on the menu and we'll be consumed. So I just want to encourage every African. HIV is a crisis in our community, and if we can't get involved to work with the leaders, if you can be proactive, it means that we will not be able to address this crisis, because if we cannot help ourselves, nobody will help us.
Absolutely. And representation matters. Absolutely. Absolutely. Melvin and Kadijah. So Augustus gets the opportunity to kind of look at it from a state's purview, but on the ground, what does your work look like in supporting folks? And either one of you can go first.
Okay, Kadijah.
Okay.
Do you want to go? Okay. Certainly, kind of looking at what it looks like for us in Montgomery County, our work hasn't waned, or just to say that the numbers haven't waned. Certainly during COVID, folks are coming in less, and physicians are doing more virtual visits, but the need is still there. Certainly, shame and stigma are still two things that are still highly reported, and I think trust is huge. We see folks from many different countries, and trust is huge. But what in the epidemic work, what we're looking at is not just having us be a sole resource, as Augustus said, inside of a building. We're looking to take what we do in this building into the community. That's going to be our biggest charge, and that's going to be where we look to, I guess, do the majority of our work. We're hitting the ground running, and we want folks who want to see providers in their community, want to be tested in the community, wanting resources in their community, for us to be a resource for them. We want to be a resource for those providers. We've kind of reached out to a couple of providers that we share patients with, and say, if you find that you're, because we can't address needs that we don't know. We can't address needs that we don't see. So if you have patients who are struggling with food, struggling with medication, struggling with housing, though, let us be your resource. We want folks to go to get care where they're the most comfortable, and not just have to come to the health department. So that's kind of how we're looking at it. But what we see, trust is huge. And a lot of folks who come to see us trust us. They feel safe with us. And so part of our then education is to then folks who then, if your provider is 2 miles from your home as opposed to the 20, 25 miles I may be, is to link you with a provider that's 2 miles from your home that will give you the same amount of care, the same amount of trust, the same amount of attention as I will.
Absolutely.
Yes.
Absolutely. Thank you so much. And one of the things I really appreciate, both Montgomery County and Prince George's County have and Augustus, correct me if I'm wrong, but I want to say have the highest number of folks who are impacted. The folks that we're talking about in this group have the highest number of folks who are impacted. And I think both counties do a really good well, even in terms of representation, but also in building those relationships. And I know it's an ongoing process. But what I've seen in your staff, Melvin, is just really a wonderful ethical, like just approach of creating that trust and building the relationships and making sure that there's representation. And so that's one of the things I really appreciate in working with Montgomery County, and Prince George's County has a similar approach. So, you know, just definitely hats off. Kadijah, tell me a little bit about what it's looked like for your work, particularly, you know, you were founded in 2012, so you've really been doing this work. I know you hit the ground running. What does that look like for you?
Well, as you know, HIV is a very stigmatized topic. I've had a lot of roadblocks along the way. I have been, you know, not welcome in some communities to talk about it because of the topic. So it's an ever-changing, ever-growing journey. And within the Muslim community, we're very, 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 very diverse. So I'm African-American, right? People think, oh, where are you from? You're from Nigeria. Like, people think these questions anyway, looking at me. But working with the African community, like so we're not a direct service organization. We're more advocacy, more education. So we don't have clients coming in to RAHMA. We go to communities. So we've done like workshops in really majority African-wise communities. Like, we have some really high populated areas here in DMV, PGMA, different parts of the DMV area. But it's diverse groups. When we started doing FGM work, we started seeing a lot more African community members because of the work that we're doing in regards to that. And FGM is also very stigmatized as well. So like, we're doing two different topics that are stigmatized. And, you know, people that came to us, of course, their identity is protected because of, you know, their experiences and, you know, what's going on. And of course, just keeping HIPAA laws, things like that in place. But we've learned so much. We learned about culture. Like, you know, you have a good heart, you come and want to do things, but you learn yourself as being stigmatizing because you're saying words that, you know, are offensive to certain cultures. So like, I've been stigmatized. I'm not going to say I haven't. And I probably will be again in the future because I'm still learning. I mean, I don't do it intentionally, right? But I learn from people. So like, when we're interviewing people that were survivors of FGM or FGC, they had different words for it because saying FGM could be stigmatizing. They might not feel mutilated, you know. So that's a very, very strong word. And then they share their stories and said, you know, some people, like their grandparents did out of love, not because they wanted to hurt them, right? So we have these different stories that they're telling us. So we have to be able to listen. And I think that's one of the main things they have when they go to healthcare providers. They feel like the healthcare provider feels like they know everything sometimes, right? And not listening to them. Or they don't have people there that can speak their language, because that can be a barrier too, or understand their culture, or understand what they need when they come to see your provider. Especially someone from an Islamic background, sometimes there's things that we need that people might not be aware of. So when we did this toolkit, we kind of incorporate some stuff into it so people can understand and look at it and hopefully utilize it. And then there is an intersection between HIV and FGC, or Katna, or whatever you want to call it, different names you want to call it. And people can become positive through the process because sometimes you're using the same instrument for cutting multiple people. And there's lifelong effects with FGM, FGC, and with HIV. Like, some of the African women they've spoken to, like, it's a big part of their culture sometimes in some countries of doing FGC. And it's like something you should do or you'll be ostracized from your community, right? And then they talk about the lifelong effects they might have had when it comes to giving birth. They have to go through the process again of being cut again so they can push out a baby. So I've learned so much, like, from these women, and I was like, wow. Like, sometimes, like, I had to try to keep a straight face learning from them. but it really opens your eyes to it. And here in the USA, doing that act is illegal. But you can't tell someone, oh, you can't do that, that's illegal. You can't come to someone's culture and their community and tell them, oh, no. They're like, who are you? Where are you coming from? How are you gonna come in here and tell me this?
Mm-hmm.
So you have to tread lightly. You have to. So what we've done when we did the FGC work is we had people from the community go into the community and talk to their community, especially the elders, like the older aunties, things like that, because they're very, very respected in the community, right? Mm-hmm. So I had a really good friend, like her early, grandma underwent FGC, and something you don't talk about, right? So you have to learn how to navigate properly through different cultures, different boundaries, and make sure that you're able to reach people to get out a certain message, but doing it in a way that's not offensive. And it's so many ways that you can offend somebody, so it's kind of hard to figure that out.
Yeah.
So I mean, no.
I was just going to say, I'm agreeing with you. I think, the key is listening. And that's definitely one of the things that I've learned along the way, is just to kind of sit back and listen and, seek first to understand and then to be understood. Right. So listen and understand where folks are coming from. And let's talk a little bit about that connection between understanding culture and being able to be culturally appropriate. I'm just going to use that word, to being able to support people. What are some of the best practices, and what are some of the things that you all have seen done? And then what are some of the gaps that need to still be filled in our community?
Yeah, I will go first. As I said in my initial opening statement, what has worked in our community is not sitting down in your office and developing an intervention and taking it to the community, but having focus group, talking with community leaders about a culturally appropriate way to address issues that affect the community. For example, we talk about female circumcision. It's true, it is a risk factor. Several cultural activities do put African at risk for HIV, polygamy, female circumcision and douching. All of those issues, all of those practices are common in Africa. But then how do you talk about it is what matters. And the way to go about it is just getting the community leader involved, raising awareness in a way that is, like RAHMA said, that is respectful to the culture and practices. But what you don't want to do is to just dismiss people's way of life. Yes, but talking to community leaders about ways we can, these factors, of course, it's a culture, but it does put you at risk for HIV. How can we work together to address issues, that fuel the spread of HIV in your community? So yeah, as I say again, community approach. And the very fortunate aspect of this is that Maryland Department of Health mission focuses on community approach, and our director for the Infectious Disease Prevention and Health Services Bureau, Dr. Peter DiMantoni, is very, very open to community engagement and so forth. And what we are even doing, we are on the verge of releasing an RFA. While it's true that the local health department are doing a great job, we also want to empower community-based organizations that have close relationship with these communities, to also empower them to provide what we call a neutral approach to a community approach, but again, HIV neutral startup approach, which does not only look at those living with HIV, but other people who tested but stay at risk for HIV. How can we engage them to prevent them from being infected? How, just every aspect of this RFA that will be out soon is about the community, using community resources. We are not only looking at HIV service organization to benefit from this. We're encouraging the RFA encourages collaboration between other organizations that organizations that are providing other services, but have connection with the community, working with organizations like Heart to Hands, who have Heart to Hand, who had a lot of experience in working with the community. So yes, we are really focusing on community approach to addressing HIV.
Yeah, and thank you so much for that, because I think it's important for community-based organizations to know that, you know, these RFAs, these requests for proposals, and basically grant applications, they're going to be coming out soon, because it is important that we really do build a coalition of services that are available. That it's not just one organization or one place, because there's a lot of people that we need to support. So I wanted to thank you, Harriet. I love your comment. So gaps, based on your experience, is lack of support group, lack of trusted voices, and definitely making sure that we have community champions that are representative, that can talk about the HIV crisis, both what it looks like abroad and what it looks like here. One of the things I'd love to hear from you, Melvin, I had a chance to work with an organization in Algeria called Green Tea, just very briefly. But what we talked about is what it looks like for someone to come from a refugee camp, for example, who is positive, who may have been there for a while, and then to come here with or without medication, or knowing what kind of medication, already with stigma, already with kind of a shield of shame, and then kind of what that looks like to get connected to care here. Can you talk a little bit about what that experience looks like for folks coming here as the provider that receives that person?
And I'm glad that you said as the provider that receives them, because as much as we'd like to try to understand kind of how they're feeling and what they're going through, it's just going to be impossible to do that. And as Kadijah said, I'll probably piggyback on that. As much as we try kind of not to re-traumatize anyone or kind of offend anyone, it could happen as a microaggression, even with our best efforts. One of the things that I guess I'll go back a little bit before I go forward, is that when working with, certainly we try to make our staff look culturally diverse. We have folks who speak different languages, but even with all of that, we only have representatives. We don't have anyone who kind of represents everyone. So listening has been the best tool, and that seems to be kind of light. But as far as working with someone, looking at them as an individual, can you teach me how to treat you? Can you teach treatment as in, I guess, and respectfully treat you as an address you, but also how you'd like to be engaged? That we found to be the most powerful tool. Not to assume that we know everything, not to assume that everyone from a particular country is going to be the same, that every trans person is going to be the same, but as an individual, in a sense, allowing ourselves to be learners and not always, even if we're helpers, teachers. And that's whether it's the individual or also working with communities. We do our outreach now. We're looking for when we're interested in hearing about need, with the understanding that there might be needs that we discover that we don't know about. There might be community needs that we don't know about, but also working with communities about solutions and being open to hear possible solutions from the community's vantage point and not just from the program vantage point. So now I said a lot of words, now to go back to kind of your question about that person, that refugee who comes here. We do our absolute very, very best when we receive that person, and in a sense to receive them in a blanket, not in a smothering blanket, but in a blanket to say, we're going to attempt to meet every identifiable need that we can. And when the ones that we can identify are raised, we will look to address those as well. We put a lot of emphasis on care. We put a lot of emphasis on medication, on medical treatment. We want to put just as much emphasis on care of health equity, social equity, mental health, substance abuse. We want to put as much on the social part because it is true. If you are concerned about where you're going to lie your head tonight, taking a pill might not be the first thing in your mind. If you're concerned about how you're going to pay the rent, how your kids are going to eat, treatment might not be. And so for a lot of folks, it's important for me to acknowledge and also recognize that person coming in, although care is important and they may be at a place where care is vital at that moment. If I have to, in my assessment, make sure that there are no other barriers to that care. I have to, as part of my responsibility, to identify any barrier and also find out from that person, in addition to this care, what else do you need? It's got to be hand in hand. It's got to be hand in hand. We find if I meet their need, then they're more likely to enter in care. They'll be able to enter in care and stay in care. More importantly, we've got a lot of folks coming in care. We got to do our job by helping people to stay in care. Yeah.
That's it. That's it. Creating a sustainable connection, a sustainable link. And I think a large part of that is being able to have support, whether it be support groups or even being able to support someone individually through the process. At Heart to Hand, we just recently started a support group for women who are African born. It's called the Lioness Ladies. And I'm so excited about it. We've met 2 times now, 3 times. And, we're growing. And a lot of the things we talk about, or some of the things we talk about are HIV related. Some of them not so much. A lot of it is about self-care. A lot of it is about just being able to kind of focus on the things that we need. As Black women, as women who are of African descent, just as women. And we want to be able to do a group similarly for our men, hopefully in the spring. So I know that there's not that many groups that are available, but I think that the outcome of that is going to be a more sustainable, it's going to be somebody that's going to be able to stay in care. Kadijah, I know that you've been doing groups for a while and you even have done retreats. Can you talk about what the successes of that have been?
Yeah, so our group specifically for African, based on origin, nationality, but it was for everybody. But we had done support groups. We do retreats every year, except for this year because of COVID. So we had people coming from across the country coming to DC for like a 3-day retreat: African, Latino, South Asian, Arab, Black. So a very, very nice gathering of people from different backgrounds. And one thing they were saying is that we felt like it was a safe space for them, being Muslim, living with HIV, and sometimes feeling unsafe to speak about it in their specific community. But I mean, also plenty of room for growth. I'm not expert in retreats. I've learned each time, okay, next time I need to add this, do this differently, have this differently, bring this person in, so that we'll have a better experience the next year. And I learned from the retreat goers. I had them lead workshops, because they are the community. They can teach each other, right? And then we also bring mental health professionals, because we have sometimes people have had a mental breakdown, they're in the middle of the night and just something happens. They just thought about something, they were triggered by something. So you had to have somebody there to speak with them. One time I had to sit with someone 2 o'clock in the morning, just sit next to them for a couple of hours because they're going through some kind of maybe PTSD or something. So you have to be equipped for that. And I know one thing you mentioned about cultural competency and how you incorporate that. So for example, in a couple of orgs here in DC, they'll ask us to come and do lead a session on how to engage with the Muslim community, because we're so diverse. We have different things that we do. And folks would think, oh, that's weird. What are you doing? Why do you do this? So having someone to kind of explain it, so when they go into the community and they see that, oh, I get it. Okay, I know to take off my shoes here. I know what that call is to prayer. I know I need to do this and that. And in that way, so we had a couple we did a couple tablings in different mosques. For example, the one in Maryland, for example. And when we had people come from Sasha Bruce Youth Work, we part of that with us. And they knew when they heard the adhan, which is our call to prayer, they knew what that was. Or they knew they couldn't go in certain spaces without having their shoes on. So we kind of did that in advance with them. I think it's important. If you don't know something, bring someone in that does, because you can't just assume or guess, because then that's not really helpful to anybody. And we've done support groups, but they haven't really done too well. We've done some virtually because people are spread out. Even before COVID, we did virtual ones, but it's still that stigma. Like, I don't know, who knows I'm in this group? Who's in here? Like, I want people to know that I'm here. So we have that aspect of it. So we haven't really done well with support groups, but we've done pretty good with retreats. And even then, people are kind of hesitant to come to the actual retreat in person, like face to face, because of the stigma that's so rampant in our community. But we really tried our best to really, really keep that secure. And we also brought in like faith leaders, like an imam each time to kind of talk with talk with their goers. And, you know, it went really well. We bring in our board members too that do work in the field. And we keep the location, you know, secret. So, come to this location on this. No, we don't do that because then it's not keeping it secure. So we don't have specific groups only for African, you know, background. We have it for everybody. People from the African background has attended as well. So I think just being aware of different things, make sure you have people that speak the language of, you have people from population that needs it. If you can speak it yourself, you know, bringing people that can actually speak to you about different cultural norms if you don't know it. And have people that actually work for you that are from that culture or that background, you can actually feel safe speaking to you about different things. So, yeah.
Yeah, absolutely. Any other thoughts, you all?
I just wanted to encourage our committee providers to, in addition to engaging clients, providing information to clients, some of these community leaders also need education. That's an approach that we can use to destigmatize HIV, because part of, the main root of stigma is lack of education, lack of awareness. So if we can take one step ahead to just engage, for example, faith-based organization, they can be a great access to addressing HIV, but it can also be a great liability, because I had an experience where we went to churches, and the notion is that people who have HIV are sexually immoral, or it is a divine punishment, you know, for those who are not morally okay, so to speak. So just putting our little time, we have the resources, just putting our little time to raise awareness. Yeah, you can go to a church, say, I want to work with you. Some might open up, but you still want to raise that awareness so as to destigmatize HIV, for us to have, you know, access to the community we are serving. I just wanted to make that. And we have the resources at the Department of Health. I'm glad. I was so, you know, excited to hear Melvin talk about the holistic approach they are taking at the department. And that's why we just don't want to look at HIV. Yeah, look at the person as a whole. And Ryan will provide those resources, medical transportation, mental health services, substance abuse care, medical transportation, linguistic services, legal services. All of these things are available to you, you know, to help those living with HIV or at risk of HIV to maintain or regain their health. So we are here to support you as program officer. That's what we are here for. If you have a need, communicate with to us, and we will look for the resources you need to help you accomplish your goal or serve your client.
Absolutely. I'm glad you brought that up, Augustus, because Ryan White not only can help, you know, provide those supportive services, but Ryan White can do it in a way that is not based on your immigration status.
Yes,
which I think is important. It's an important point to make, because on top of the stigma of HIV and sex and shame, there's also immigration status. I think when folks are here, you know, particularly in this environment, like who knows what, right? So it's important to know that you can go to the health department, you can come to Heart to Hand, you can work through RAHMA to be connected to care, to organizations, and that is not dependent on your immigration status. It's making sure that if you are living with HIV, you can get connected to care. particularly in the state of Maryland, in the District of Columbia, and in Northern Virginia. And this EMA, you can get connected to care. I think that's a...
Yeah, if you grant me, we had complaint of not that many, but we have complaint where providers will discriminate against a client that are not documented, and they make it to appear that immigration status is a requirement for Ryan West services, and I just don't find this okay. I'm glad you brought this up because Ryan West services is not tied with any one immigration status. So yeah, we should do away with these injustices. If our job is to, I'm not saying a lot of people do, but we have heard these things happening at HIV service organization.
And just to tie that back to, I guess, the question that you had asked me before about the refugee coming in, part of the trust building is that knowing that services are not linked to immigration status, they're not linked to whether someone has income or not, they're not linked to language, whether someone speaks English or not. That kind of building that trust is that services are available, period. And it's our job to kind of help assess your need, but that there are no limitations to service based on where you come from, or whether you have a job at the moment or not, or whether you can even afford care. So you're absolutely right. I'm glad that you brought that point up, because we also use that as part of our trust building. Certainly in this climate, we had a lot of folks over the last couple of years that's been huge. When folks fear that ICE is just around the corner, that has been a huge, making sure that when you ask kind of what one of the biggest risks to folks falling out of care, that was it, is that all of a sudden where they got care, the folks were coming here, potentially that this was no longer a safe place. What's going to happen to me if I come to your location? So building and maintaining that trust has been crucial. And that has been certainly one of the most important areas of reinforcing that you are safe, that we don't care, and we don't care, we're not reporting, nobody's following anything. But it takes a little time to build trust. And as part of that whole building a rapport, that we found out that that's been an important issue, is some folks might say, of course we'll see anybody. No, it's important that we acknowledge people's fears. So whether it's that or fear in general, it is really, really important that we acknowledge fear or any other barrier that's going to prevent folks from getting and staying in care.
Absolutely. That's our job. Augustus, so we have a question in the chat about information of where clients could report complaints if they do feel like they've been discriminated against, or they feel like somebody has refused service. And is that something?
That's a great question. Most providers have a consumer counsel. Do you have that, Melvin? Do you have department?
I'm glad that you asked that. And in complete transparency, we don't at the moment, but it is something that, believe it or not, the building blocks are in the works to do that. So we do have an internal mechanism that if someone who comes to see us has a complaint, that there is a flow internally. I like the fact, though, that if somebody doesn't trust that they can report something here, that they can go to the state. I'd like that. I'd like the fact that people have an option, because sometimes, let's be honest, sometimes people might not be comfortable reporting something to the provider which they see, certainly maybe even a Ryan White climate where they're getting care. So we have some mechanism internally, but I like the fact that there's something at the state if somebody felt more comfortable or did not feel comfortable saying, well, some folks might fear if I report, then people may not see me. What do I do for care? So I like the fact, Augustus, that there is a place where they can go anonymously or not anonymously to report any feelings of not being treated fairly.
Yeah. So we required our providers to state clearly if these things happen, whether there are procedure in place to address client grievances as part of our plan or condition of award. So yeah, we have those in place so that it starts internally if the problem is not addressed before it gets out. So the provider would when a client is admitted into the program, they educate them on all of these, what to do if you have complaints, if you are not satisfied with the services, if someone discriminates against you. So if it is not addressed properly before it comes over to the state, but it begins at the provider's facility.
Absolutely.
We have something in place, and that's also and other agencies have consumer counsel, and that could also address those issues.
Absolutely.
So yeah, to answer a question, there are ways to address the clients' complaints as part of our award. Giving our award, we lay those conditions before we even award our providers.
Absolutely. We have, in following those conditions, we have a client grievance procedure that we explain to clients as they come into the organization. There's a consumer advisory board that we have where complaints can be forwarded to, and then we can be held accountable. You can go to the state, like Melvin said. I think I appreciate that too, that we and other organizations can be held accountable, that we provide the services that we are funded to and are supposed to provide for the community. There's also, one of the things I appreciate, Kadijah, about your organization is that you are an advocacy organization. So oftentimes you can serve as the voice for those who may not feel comfortable, or at least guide them, those who may not feel comfortable, on how to speak up and how to make sure that folks are being held accountable through advocacy services.
Yeah, so again. So like people don't want to talk about it or be open about it because of the fear of backlash or stigma. So many times people like myself or others who are not positive, we kind of like share what they want people to know. People who are positive that are open, and they'll share the information as well and be advocates on behalf of those who want to not speak out publicly. And also, I am a faith ambassador with the COVID-19 Prevention Network, and it's about 6 of us across the U.S. that are part of different faith communities, and we go around and do educational workshops with different faith communities about COVID, what's going on, what's happening, And one of the main things that I've seen also is that people who are from immigrant communities might not go seek care, right? Because they might be afraid that they might be deported if they're not, here, if they're not like a resident or have the proper paperwork or so on and so forth. So with COVID, we're seeing even more things happening within the immigrant community, and the distrust and not knowing who they can go to get care or who they can talk to. And so that's something we're navigating as well. And so it's just, and then people we know now with COVID and HIV, there's an effect on that. People are dealing with more depression, or if they are alone, they don't have someone they can talk to. They can't constantly go out now and get that social interaction that they might have been used to. Or like we have people by part of RAHMA that we worked with in the past that have gotten very severely depressed because they're like extroverts. Now like everything has just like stopped and came to a standstill. So we have to take that into account too. And then if you are someone who doesn't have health insurance or someone who doesn't have get a mental health counselor to speak to, or you can't get this person, that person to help you through this. So this is weighing heavily, definitely immigrant communities, Black communities, Latino communities. There's so many of us that are being really affected by COVID. And then we already had HIV. We already had other different things going on before COVID. So trying to figure out how to navigate all of this. So yeah, this is some things that I've seen within the past 9 months, 10 months has it been?
Yeah, listen, it's been a minute.
It was like it's just been here for so long. Like when is it gonna end? Like when can we get back? Or when can we start doing things again? Because people's mental health being severely affected. And I mean, I've lost members of my family to COVID, and others have as well. So it's like dealing with loss too and grief can be really hard on people. And then a lot of resources are being taken away from HIV to go towards COVID work, or things have been stopped and funding has been cut and all these different things. So that has an impact as well.
Yeah, and I just want to add that not to bring politics to the table, but it's the fact the Trump administration has not been immigrant friendly, so it does affect how people access health services. And I'm not ashamed to say thank God that he's going. Yeah, because we can't have our people live in fear. Yeah, yeah.
No,
in the beginning, like we had people called to the Muslim ban and all these different things. We know a lot too. With our current administration that's going to be on the way out. But hopefully we'll see things happening differently, and hopefully people that are immigrants will feel a lot more safer here, or feel trusted, or build trust with some organizations, some different people, because a lot of us don't.
Yeah.
A lot of people don't. That's what I want to say. So, yeah.
Absolutely. Thank you. We have about 10 minutes left. And one of the things that I really heard over and over again, and I'm learning from this too, I was taking notes, is that, you know, as community-based organization and as organizations that are here, is that it's important for us not to be passive, as Augustus mentioned, and to really get out and to figure out how we do this work, how we go to the community. Kadijah, even in this environment of COVID and having to do a lot of things virtually, I think it's going to be important for us to figure out ways to get out. And so in kind of leaving this conversation, and we could go on, let's just be clear, we could go on for hours about this because there's just so much to talk about. And so I so appreciate you all's time. But what would you like, you know, for our viewers to walk away with in terms of, you know, what's that action step that either your organization is going to take or that you need help in terms of connecting with the community?
I will start. Actually, I won't regret saying this. I'm going to say it. With our EHE efforts and saying that it's going to be largely community-based, we're going to go boots on the ground. We're putting a plan together, even during COVID, that as when things lift, that it's already in place and it won't be something that we're starting to do. And I want to be held accountable for this. I want, my hope is that you, Kadijah, your Augustus, saying we are hearing what Montgomery County is doing. Actually, we're not just hearing what they're doing, we're seeing what they're doing. We're seeing the actions that you're taking. We're hearing community leaders saying that you are reaching out to them, that you are fostering conversations, you're listening to them, and you're looking to act. That's kind of what I want you to hold my feet to. If we're here a year from now, I'd like this conversation, at least a part of it, to say, Melvin, this is what we have seen that you have done. That, and I want you to hold my feet to it. That's how I guess confident I am just about the plans we're putting into place, the things that I'm already seeing. I'm starting to we're still at that seed level. We're still at the seed level, which means you're not hearing what we're doing yet. As the seeds break the soil, hopefully you will start to hear murmurs. As those plants start to take root and start to grow, that's when I hope that you're saying, this is what he's talking about, of having a community presence. I don't want, in a sense, we kind of been in that big, was it like the Mormon temple in the Beltway? We've been that's where we've been like in Montgomery County, where the health department is. If you can make it to our building, you're going to do great. We don't want to rest on that anymore. We want, in a sense, to have that same presence in the community. So I'm asking you to hold me to that. I'm asking you to ask me. It's okay to ask me for updates. What are you doing? Who are you talking to? What actions are being done? And so if we are here, my wish is, if we're here for a year from now, you'll be able to tell me what we're doing. You'll be able to tell me what we're doing. You'll tell me what you've heard.
I love it.
Yes. Well said, Melvin. I'll hold you accountable.
I know you will.
Yes. And I I just want to say this, that I want you to use me, guys. Yeah, sometimes I have less to do. Use me, to engage the African immigrant community. I'm very passionate about it, and I think Ann knows about that. And Melvin, I work with you.
Yep.
Kadijah, I'm willing to work with you anytime. To connect you with the right people, the resources you need. That's my job, to support the work you do, because your success is our department's success. All right. So please use me. I will share my mobile number with you, Kadijah. I'm sure Melvin has it. If you need me, any connection you need to reach the immigrant community, anytime, even midnight, I'll be able to respond.
I'll
Maybe
vouch
not
for
tonight.
that. I will vouch for that.
guarantee.
Got you
Yeah,
back.
I mean it. I mean it.
The beauty of stuff like things like this, people are connect and then they go offline and continue to do the work together. So I enjoy it.
Absolutely. Absolutely. And I mean, that was really the point of this, that was one of the points of this, is to really, to know that we can hold all of ourselves accountable. Heart to Hand has done a lot of work with the Prince George's County in the epidemic effort as well. And so same thing, Melvin, we're still in the seeds, but we really, really want to be able next year, this time, to have made a difference. And I know that Miss Harriet is watching, and I just wanted to definitely acknowledge, like, the Montgomery County African Affairs community has done a great job of just mobilizing business people and just people from all walks of life. And I know that there's a similar organization in Prince George's County that we hope to get involved with, because we do want to come out. We want to make ourselves available, and we are available. We can come out, we can do talks, we can connect people to care, we can do a group thing, we can do an individual thing. We are available, and it won't be, we know that we can't just sit back anymore, that we've got to be able to get out. We've got to create those community champions who can also work with us so that we can end this epidemic, because we can get there. I believe we can get there. Definitely. Kadijah, what would you like for us to take away?
Well, since we're definitely all saying a year from now, I like to see us back out in the world, number one.
Yeah, that part.
Another thing,
Absolutely.
I want to see RAHMA grow. Like, we're a very, 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 very small organization. We're trying to get more funding and grants so we can do more work and hopefully have a further impact. We got a small grant through DC Department of Health. We're focusing on South Asian women, and we're going to focus on, sexual health education, HIV, FGM/C, and gender-based violence. So we're planning a big program in April around this for just women of South Asian background descent, because the grant is catered towards, but we brought in people that are from the community to help develop this program. So we want to do this for everyone. We applied for African one as well. We didn't get it, unfortunately, but we want to kind of do it for African community as well and other communities. So it's very important to make things culturally based so that can kind of connect, and be more understanding. We brought in people who are from the community also to lead these different events. So my goal for year now is to really, hopefully, work with the community more, learn from the community, hopefully have some growth so we can reach more people and really address the stigma that we're facing, and hopefully continue to connect with you, and also learn. If people have something they want to say about RAHMA or give us any feedback, I want to hear it, because I'm learning every day. By no means. So please, if you see something on RAHMA they feel it can be better, let me know. My email, we can put it here, is Kadijah@rahma.org. Email me. But yeah, we're definitely. Oh, okay. Excuse me.
We got you. I told you.
So yeah, definitely. We want to really connect with more communities. We're based in DC. We want to be a national organization, and we have a lot we can do to get there. So let us know. I'm here.
Definitely, and there's a lot of work that we can do right here in the DMV. So.
Yeah.
Absolutely. And what was? Oh, go ahead.
Yeah, and if you permit me, I just want to just tell you another project we have embarked on at the Department of Health is to develop our strategy for African immigrant or all vulnerable populations that we will after the completion, gave it to provider to help facilitate your work. So we intend to use community members, consumer, providers, and to develop this too. And it will also have places where African or the vulnerable population congregate so that you can use it. For example, for African immigrants, if you want to get them, the faith is a huge part of their lives. Okay, barber shop, grocery store, just where they congregate, those places, in addition to those strategies, to make your outreach much easier for you. So we have the address of maybe one of the popular grocery store in Montgomery County that African go to buy food. So if you want to reach there, you can easily reach there. So we are working on this thing to support you. So keep doing the good work you're doing, and we have your back. You are not on your own.
I appreciate you so much, Augustus. You're going to keep us on our toes, I know.
Yes.
Thank you all so much. I so appreciate your time. I appreciate your work. I appreciate all that you do. This has been a great conversation, and we'll make sure that we put the links to your organizations, within the chat, and when we post it, we'll put the links to your organizations. But I really am honored to work with you all, and I so appreciate your time today. So thank you so much.
Yeah. Thank you very much, Anne.
Thank you, Anne, for having us. Yeah. Thank you.
All right. So please stay tuned. Keep an eye out for more information about resources that are coming out. Augustus is going to keep us on our toes. Melvin and Kadijah and I are going to get moving.
Thank you.
All right. Thank you all so much.
Okay. Bye-bye.
Bye, everybody.